I think that regarding the challenges we have in treating patients with triple-negative breast cancer, we have at least 2 or 3. Maybe the most important one is about the prognosis. This is a patient population with a very bad prognosis, basically when the tumor becomes metastatic. The second one is that we have very limited activity with cytotoxic chemotherapy today, and this is basically true beyond first. The number of targeted agents approved in triple-negative breast cancer is poor. Maybe we can discuss the role of bevacizumab in some countries without having improved survival, and atezolizumab also in some countries for PD-L1 positive patients and in combination with nab-paclitaxel. So different challenges, and this is why, in my opinion, we need more and better drugs in the next future. KEYNOTE-355 is a randomized placebo-controlled phase 3 study which explored the role of pembrolizumab plus chemotherapy compared with placebo plus chemotherapy in the first-line setting of metastatic triple-negative breast cancer. Chemotherapy backbone included nab-paclitaxel or paclitaxel or carboplatin plus gemcitabine. So this opened the possibility for the patients to be treated with different chemotherapeutic compounds. Regarding the primary endpoints, it had 2 co-primary endpoints: progression-free survival in PD-L1 positive tumors, and, if positive, also in the intention to treat population. And second co-primary endpoint was overall survival in the same patient population. Secondary endpoints included overall response rate, duration of response, and safety. We have learned 3 or 4 key points. The first one is that pembrolizumab improves progression-free survival not only from a mathematical or statistical perspective, but also for a clinical perspective. The hazard ratio for patients with PD-L1 positive CPS 10 or more was 0.65. The median progression-free survival moved from 5.6 months with chemotherapy and placebo to 9.7 months with chemotherapy plus pembrolizumab. The second is that although a clear trend to improve survival, to improve progression-free survival was also observed in patients with PD-L1 CPS 1 or more, this did not reach the statistical significance. That is why we cannot formally say that pembrolizumab improves progression-free survival CPS 1 or more, but only in patients with CPS 10 or more. The third thing we have learned is that when we combine pembrolizumab with chemotherapy, the adverse events were not increased. And again, grade 3 to 5 adverse events were not increased. However, as expected, grade 3 to 5 immune-mediated adverse events were increased from 0% to 5% because of hypothyroidism and hyperthyroidism. So in conclusion, pembrolizumab improved progression-free survival without adding significant toxicity. I think that the role of biomarkers, where we have to select the optimal treatments for our patients, is key. It is key for endocrine therapy. It is key, but also for immunotherapy. And what we have learned from the KEYNOTE-355 is that we can optimize the group of patients who will have the optimal benefit from the addition of pembrolizumab to chemotherapy. And this group of patients are those ones with tumors enriched with PD-L1. And the expression of PD-L1 has to be measured with a CPS score, DACO platform, antibody 22C3, and it has to be with a CPS score 10 or more. This is the group of patients who might benefit more from the addition of pembrolizumab. Of course, it is true that we need more biomarkers to help us to optimize even better the patient population and chemotherapy. I think we have different next steps we are waiting for with pembrolizumab in triple-negative breast cancer. The first one, of course, in the triple-negative setting, we have to wait. We all expect pembrolizumab improve survival, but this is something we have to see. But second, we should not forget that we want to cure more and more patients. And today, this is what we can achieve in the early breast cancer setting. The KEYNOTE-522 explored the role of pembrolizumab plus chemotherapy in the neoadjuvant setting, and pembrolizumab improved pathological complete remission, but it would be great invasive disease-free survival. This is something we will see in the very next future. And finally, I think that exploring the role of immune checkpoint inhibitors after immune checkpoint inhibitors is key. So maybe pembrolizumab in the second-line therapy could also help patients who have been pretreated with pembrolizumab in the first-line setting. This is something we still do not know, but that's something that, in my opinion, should be explored.